Citrate anticoagulation, quick review. Ionized calcium is necessary for many parts of the clotting cascade, both intrinsic and extrinsic pathways. Citrate chelates or binds with ionized calcium in the patient's blood, making low calcium blood that is resistant to clotting in the circuit. This results in anticoagulation. Citrate is infused into the blood flow path through the access line from the PBP or the pre-blood pump. Circuit ionized calcium is drawn post-filter with a target ionized calcium of 0.25 to 0.4. As citrate is infused into the blood flow path, it drops the ionized calcium. This calcium-poor blood flows through the circuit and is pushed back to the patient according to the blood flow rate. So for a blood flow of 50 mils per minute, that is 3 liters per hour of calcium-poor blood returning to the patient. For 200 mils per minute, that is 12 liters of calcium-poor blood per hour returned to the patient. This would drop a patient's ionized calcium 0.25 to 0.4 very quickly. Therefore, a calcium chloride infusion must be administered to the patient during CRRT. Additionally, the dialysate solutions have zero calcium, which further diffuses calcium out of the patient's blood. Even if a patient did not have citrate, because of the zero calcium dialysate, they would require a calcium chloride infusion. Citrate is cleared primarily by the liver and also skeletal muscle and kidney, and some portion by the dialysate. In patients with liver failure or receiving high amounts of citrate due to patient size, like our neonates, the liver cannot clear the calcium citrate complexes. This results in a buildup of calcium citrate complexes called citrate toxicity. Citrate toxicity can be detected by a high serum calcium, measuring bound and unbound calcium, and a low or low normal patient ionized calcium. This shows accumulation in bound calcium while still having not quite or just enough ionized calcium for the patient. A high serum calcium with a high ionized calcium is simply too much calcium to the patient, as shown in example 1. Example 2 shows citrate accumulation, evidenced by the discrepancy of the high serum calcium and the low patient iCal. Citrate toxicity can be treated by increasing the dialysate, or in some cases, proportional decrease in citrate and calcium infusion rates, as prescribed by the nephrologist. Increasing clearance is not selective, so this increases removal of nutrition, medications, and other things, in addition to removing more citrate calcium complexes. Here are some advantages and disadvantages of citrate anticoagulation.